Okay. Now, do you have any questions regarding the NIH stroke scale? Any confusion? No. Now, the whole idea of doing a yeah.
Yesterday, we've got a patient in bed, I think it's bed 2, and they were on Diprovan and different stuff, and people were trying to figure out how to assess this patient. And we were trying to figure out what we should do as far as what to pick if they're not doing anything. If you can't get them to do anything, or if you turn it off.
If the patient is number 3, you can do an NIH stroke scale.
Okay, yeah.
You have to go back to Glasgow Coma Scale. That's the coma scale. Patient is comatose, go back to coma scale. He has to be able to respond in some way for us to do an NIH stroke scale. And honestly, if the NIH stroke scale is more than 25, it doesn't help at all. 25 means a very bad stroke. So no matter how high the number goes beyond 25, it doesn't really count.
Like whoever filled out the assessment thing across the street, they don't do a whole lot of clinical stuff. They just put down, I guess, whatever the answers they think should be, but they don't know the situations that we're in.
Yeah.
So, like, there needs to be probably, I mean, on this probably, just so you'll know, I don't know if you ever get on the computer and look at it, but the thing of it is I guess there needs to be a thing on there where you can say patient is either on sedation. Of course, they had the sedation turned off, and the patient still didn't do anything like you said. So you'd have to go by the coma scale.
Coma scale.
But
there's no option
we were all trying to figure out what to put, but there's no button to click on the computer to say that they're not doing anything. So you're sitting here on the computer going, well, what do you put? And I said, well, I just put in the order. You know, there's a place where you can write and just put what's going on.
Okay, we need to fix that. Okay. Now, the modified NIH stroke scale is also the same as the same NIH stroke scale. The whole idea, I mean, to answer the question why we're pushing for NIH stroke scale. Now, it's like, the currency of whenever you sign out amongst yourself and whenever you call a person on call with a neuro change. Now, we want to know what was before and what is it now, and we want to be able to quantify. Was it 8, now it's 12, was it 12, now it's 20? So that gives us an idea about what the patient looks like. And beforehand, when you tell us, the push and pull and foot grasp and this and this purposeful, that doesn't really make any sense because we are wired to think in terms of NIH stroke scale. When you get a TPA patient and when you have a order Q1 NeuroChecks, that's when the modified NIH stroke scale comes in very handy. Not really when you're doing NIH every 12 hours. Usually when you get used to it, doing NIH will just take like 10 minutes, even less than that. But when you have to do Q1, Q2 NeuroChecks, then NIH will come in, modified NIH will come in real handy. The whole idea is to choose the pertinent things from this entire scale and score them. Now, the most important things are 1A, the level of consciousness. We want to know what the patient looks like, irrespective of whether it's right brain or left brain stroke. So same questions, looks alert, looks drowsy, or uptunded. If someone was alert and getting drowsy to uptunded, that's very important. Orientation questions, you can ask any questions. You don't have to ask the same questions every time. What's your name? What's the month? You can modify your questions. Response to command, same thing. Ask them to do 2 things. It doesn't have to be open your eyes, close your eyes, or open your hand, close your hand. You can modify it. Choose 1 for midline command, like open your mouth, show me your tongue, and 1 for the arm or leg commands, whichever one you want. Gaze, it's not really important at this point. Visual field, not important. Face, yes. What does the face look like? Was there not a facial droop? Now is a facial droop. So that's important. So we'll choose 1A, 1B, 1C, number 4. And the motor function. Now, if strokes are by default unilateral, right? You don't have to keep doing the both sides exam if you are doing NeuroChecks for a stroke patient. So you come in, you get a new patient, you do a baseline whole thing, and you have an NIH of 12 scoring mostly on the right side. You know it's a right body stroke. Why do you have to do NeuroChecks every 1 hour on the left side? Doesn't make sense. So on the motor side, choose the one that's symptomatic and do the same thing. Drift, no drift, can't move, no anti-gravity, and score the same way. Ataxia, not important, you don't have to check it. Sensory, not important, you don't have to check it. Now, number 9, language. You already get an idea from 1A, 1B, 1C what the language is. Is the patient able to answer a question? Then probably that patient is not aphasic. If the patient is following commands, probably not aphasic. So you already have an idea. If it's 2 or 3, you already have an answer from there. Not following commands, not answering, mute. If it's answering questions, following commands, but you don't have a full grasp on aphasia, then you do the language testing, and you don't have to bring your card and ask them to read and name and all that every time. You already have an idea. You already did your baseline whole NIH stroke scale. So randomly ask them to name something, a flashlight, a pen light, your watch, and listen to the articulation of speech. You'll also have idea of the dysarthria there. And you don't have to have them read things or name the objects in the card. You'll get an idea whether it's 3 or 2 or it's just 1, from 1B, 1C, and a little bit more there. Now that'll be the language, and while you're talking, you already know whether it's a dysarthria or a severe dysarthria. And you don't really have to check extinction. So this will be like a Q1, Q2 NeuroChecks if you're doing that for a post-TPA patient. So this is all about the modified NIH stroke scale. It'll probably take you the same time as the current thing that you use the GCS for now, for NeuroChecks. Yeah, probably the same time. So as long as you're taking the same patient, same person, just do a modified, because that's what we do when we round every day. Any question?
I don't know if it's just they just want us to do it more so people can learn, be able to do it better and understand it more. But like they want us to do it like every 12 hours. I mean, pretty much every shift, a full one every shift. So, I mean, I was under the impression when we first started doing all this, that you did it before you did the TPA, a little while after you did TPA, and pretty much as they left the hospital. I mean, that's the way it sounds. But I don't know.
The problem arose when there is a neurochange, and we want to identify when the neurochange was. So the doctors rounded morning 8 o'clock. NIH documented was 4:05. Comes back the next day, and the NIH is like 16 or 20. Now, what time it happened? We tried to look at the NeuroChecks that we do currently. It really doesn't answer that question.
You mean as far as the Glasgow coma?
Yeah, it didn't answer that question at all. So more and more institutions, they are, using the modified NIH, because it's cumbersome to be doing this every 1 hour, every 2 hours. So as long as one person is taking care of that patient, when you come in your shift, you will be taking care of that patient maybe for the next 3 days when you're working. You don't need to do an entire NIH stroke scale every time when you do a NeuroCheck. So once you get an idea about the patient, you just do a brief, focused, modified NIH depending on the kind of deficit that person has. And that'll be more reliable than the Glasgow coma scale.
So what you're saying is, let's say the patient was ataxic when they were admitted, you have to use your own discretion.
Yes.
I mean, whatever problem they had with the whole Glasgow coma, then you want to pick up and follow through and evaluate that as far as worsening or.
Keep an eye on it.
Yeah.
Yeah.
You can't just,
Yeah.
It's not exact cookbook for everybody.
It's not. It's not. And we will miss strokes like posterior circulation strokes with the focused NIH if someone has a visual field problem. you don't need to do the visual field exam every 2 hours if they don't have any motor weakness, right? You just can briefly do a motor exam, lift your legs up, lift your arms up, and check their speech. The whole idea is not to miss those strokes that can worsen, meaning anterior circulation strokes, right MCA, left MCA strokes, because these are the ones that worsen more frequently. So it's every shift, that's what, okay.
As far as that's what I was, every 12 hours.
For the big one.
For the big one, that's what we're told.
And then Q1 or Q2, the modified is what?
Oh,
you've
okay.
got.
What-
Is
what
that
you're
what
saying.
y'all are wanting? Y'all are wanting a modified with our NeuroChecks, either Q1, Q2, whatever.
Modified,
one,
yeah.
And then a big one every 12?
Every 12 hours, yeah.
Okay.
See, the thing with that is they're gonna have to either fix the nurse's notes.
So we need to fix that, yeah.
Because none of that reflects none of that.
If someone is tubed, someone is intubated, someone on propofol, you can't do NIH. You can do
But I
NIH.
mean, I don't know if you can just do part of the NIH scale on the computer. I think you have to have something in every blank to be able to, for the computer to accept it. And that's where you come in the problem, where you can't say, hey, you can't do, you know, the gaze or whatever, you know, the visual fields, or if they're not doing nothing.
Then it could be like an NIH quick and an NIH stroke scale tool, kind of like we've got ICU and ICU quick set up now.
We just need to get, maybe get George to talk to the people across the street and get them to
I'll
figure out what to do.
I'll call Gail later, Gail Maynor later today and get her working on it.
Yep.
Cause they ought to be able to put the modified like on the quick ICU or
Right.
something.
And then maybe add something like, I'm about to intubate or on sedation or whatever.
Yeah, or if it's 3 and 1A, coma unresponsive, then do a Glasgow coma score. Well, it wasn't an hour, it was just 13 minutes, looks like.
Now you owe us all breakfast.
But it was power packed, though, hey. Good job.
No, the ER is crazy. There are like 50 patients down there. It was crazy last night.
We're gonna have to learn how to shut the door down there.
Yeah. At least 10 ICU holes, probably. Okay. Any questions? Anything else?
One more time, what numbers on modified?
So 1A, 1B, 1C,
Okay,
face,
okay,
and motor function, depending on which side was affected,
okay.
and 9 and 10. Any other questions with anything related to neuro or?
Do y'all order 10-hour NeuroChecks for every patient in neuro, or is it just certain?
Q hour for those who are in the ICU. That means they're either having a bad stroke or they are treated with TPA or endovascular. So if you look at the order set, it's probably Q1 hour for what?
Well, supposedly, this is a ICU protocol.
Yeah.
Once we admit them in ICU, it's every hour for the first 24 hours.
Yeah.
Unless there's some kind of a change or they're on time drips. And then they can, depending on what the doctor wants to do and how they're doing, you can put them on Q too.
So Q1 hour.